session about pregnancy after breast cancer. Dr. Ebeaid Omar from Kenya will give us a talk about pregnancy after breast cancer diagnosis.
Bismillahirrahmanirrahim. Good evening, everyone. First of all, I'd like to begin by thanking Professor Abdul Salam Atiyah, the head of the Department of ACOD, for giving me this opportunity to present in this great occasion over here. This is a great honor to me, and it means a lot. I'd also like to thank the organizing committee for accepting this topic. So we are going to discuss about pregnancy after breast cancer. My title of the topic is, Are Young Egyptian Patients Willing to be Pregnant After Breast Cancer Diagnosis? This is the experience from the TRUE Center in Alexandria. So this is a real world data for our local setup. And this is going to be the plan of our talk. I'll start by overview, followed by introduction, the research and methodology results, conclusion, the future direction, and I'll conclude by the take-home message. This is the overview. Breast cancer is the most prevalent malignant of reproductive age. There's an increase of breast cancer incidence in young women less than 40 years old. In the developed world, the incidence of breast cancer in less than 40 years old is around 7%. However, when we come to low and middle income countries, this incidence goes up all the way to around 20%. Recently, there's an improvement in diagnosis and treatment. Therefore, we are seeing more survivors in breast cancer, especially the young women. Nevertheless, there's an increasing trend of delayed childbearing. Nowadays, most women, they have their first child at around 30 years old or later. Some of them, they have not even completed their family, or they are about to start having children. That's why this is becoming a great concern. Coming to treatment, the side effects, especially the chemotherapy, and the longer treatment duration in hormonal positive, which was approved based on the ATOM and the ATLAS trial. Nowadays, we have longer treatment schedule, around 10 years in some of the hormonal positive patients. Therefore, this brings to our topic of discussion, making fertility becoming a great concern. Breast cancer treatment involves surgery, chemotherapy, radiation, hormonal treatment, and target-directed therapy, and this has a direct impact on survivorship. This is a very big slide I borrowed from Shani Palucci in the recent presented breast cancer in young SO5, BCY5. However, we are going to focus on the reproductive. These are the issues affecting women. So in the reproductive part, the patients with breast cancer, they undergo premature menopause. They have long side effects of endocrine therapy, the fertility issues, the pregnancies and sexuality and sexual dysfunction. In young women, most patients undergo mastectomy compared to breast conservative surgery. According to the paper which was published by Rosenberg in JAMA Surgery recently, this was a paper which involved around 1,000 patients. Approximately 50 patients underwent bilateral mastectomy. However, among these 50% of the patients who underwent bilateral mastectomy, only 20% were BRCA positive. That it means there are still some more patients who undergo bilateral mastectomy despite being BRCA negative. And this has been shown to have direct effect in the quality of life, especially most female patients undergo, they have anxiety, their body image, and it affects their sexuality. Another paper published by Rodi, it showed that 50% of women are concerned about their fertility before starting the treatment, and this has led 26% of them to change their decision. A number of patients decided either not to receive chemotherapy, or they preferred one regimen over the other. Some patients, they declined to use endocrine therapy, or they preferred to use the shorter duration of endocrine treatment. Some of the patients even declined to undergo MRM. However, besides all this, only 10% of the women took fertility preservation strategies, And it has been shown that, and it's already known that young patients, they have poor compliance to endocrine therapy, and this leads to poor outcomes, and their main issues, the infertility and many other complications. We know that chemotherapy induces premature menopausal ovarian failure, and this depends on the age of the patient. Older patients around 40 years old, they have higher chance to undergo ovarian failure compared to the young patient. Again, the regimen of the chemotherapy used also influence if the patient will undergo ovarian failure or not. However, there are methods which we can use to preserve the fertility, which include cryopreservation of ovarian tissue, embryo and oocyte preservation. But these methods, they are not applicable in some places due to the culture and the religious issues. Therefore, we see most people, they use the GnRH agonist to be the main method of fertility preservation. So our big question is, do young women desire to have children after breast cancer diagnosis? Yes, there's a surge of delayed childbearing age, as we had already talked in the overview. There's more women are now diagnosed with breast cancer before completing their families. Out of these, 47% desire children after the treatment of breast cancer. So who are these patients who really desire to become pregnant after breast cancer? Most of them, they are young women, and these are the patient or the female who don't have children, or their parity is only 1 or 2 children, so they prefer to complete their families. So the big question is pregnancy safe after breast cancer diagnosis? Yes, pregnancy is considered safe after breast cancer diagnosis, both in hormonal positive and germline BRCA positive patient without worsening the maternal prognosis. There's a meta-analysis which was conducted by Hatim et al. Hatim Azim is well known to all of us. He's the son of our soil. He conducted a meta-analysis of 14 trials. It showed that patients who are hormonal positive, if they become pregnant after breast cancer diagnosis, they don't have any worse prognosis compared to the hormonal positive who never went prognosis. In fact, in their further sub-analysis of this in this work, they showed that patients who became pregnant, they even had better survival compared to the patients who never became pregnant. Again, there's a recent paper which was published by Lambertini et al. So Lambertini and Hatim, these are the most people who are involved in doing the work of pregnancy and pregnancy after breast cancer. This paper was published recently, you can see there in 2020. They showed that they did a multi-center trial which involved around more than 5,000 patients who were diagnosed to be BRCA positive. Out of these BRCA positive patients, around 1,000 patients, they became pregnant. In the final analysis, it was shown that there was no survival difference between the BRCA positive patient who became pregnant and those who never became pregnant. Now the big question, when is the best timing for this patient in hormonal positive can become pregnant? This question until now, it has not been answered. However, it has been shown that according to the same meta-analysis which was done, the patients who become pregnant 5 years after diagnosis and the patients who become pregnant 5 years before diagnosis, there's no survival difference. So now this begs the big question, should we make our patients wait for 5 years before becoming pregnant, or they can safely become pregnant before this? We'll see this when we are looking at the future direction. However, as we move on, we can see that some of the women, they become pregnant while still on tamoxifen treatment, because maybe these patients, they were still on using contraceptive, or they wanted to become pregnant and their physician ignored this urge of them to become pregnant, and they become pregnant still using tamoxifen treatment. We recently published a paper which this is a patient who was in our department. We published it recently showing that tamoxifen exposure in pregnancy after synchronous breast and thyroid cancer. Breast cancer has the least probability of successful pregnancy. We can see from this figure over here that breast cancer, the bottom over there, it has the least probability of becoming pregnancy compared to other malignancies. And this is already because of the reason we have mentioned previously, longer hormonal treatment, the chemotherapy leading to ovarian failure. So this patient, compared to other malignancies, breast cancer has the least chance for one to become pregnant. And this takes us to the aim of our research. I'd like to mention that this is the data which I've extracted from my ongoing thesis work, which was entitled The Outcome of Young Egyptian Patient with Breast Cancer, a two-center experience in Alexandria. But today we are going to focus on the young patient who expressed a desire to become pregnant after breast cancer diagnosis. We are going to present the clinical pathological characteristic treatment briefly. This was the method. It's a retrospective study conducted at the Alexandria Main University Hospital and Ayadi Mustakbal. There's a mistake over here. It is from January 2008 to December 2017. So this is a 10-year period of collection of data, and we followed them for further for up to 2019. So some patients were followed up more than 12 years. These are the inclusion and exclusion criteria. And this is the results. There was approximately 900 young breast cancer patients in this period. We excluded 852 patients who had no desire of becoming pregnant. So we remained with 48 patients who had asked the physician the possibility of becoming pregnant. Out of these 48, 21 were unsuccessful, they never became pregnant. Only 27, they became pregnant. Out of the 27, 17, they delivered successfully. However, 10 patients, they decide to abort. Either the physician is the one who initiated the abortion, or the patient herself, she never prepared to continue the pregnancy. This was the age distribution. The mean age was around 32 years old, so you can see this is quite a young group of patients. Nevertheless, the age range was from 23 years old up to 40 years, a range of 17 years. And these are the clinical pathological characteristics of the patient. We can see here on the top of the table, most of the patients, they were young. Around the age of less than 35% were forming the majority of the group. And most of the patients had only around 37% had the family history of breast cancer. You can see in the parity over here, we have most of patients around 17 patients who had no children. One is 4.8% in the patient, the group which they desired. However, in the group where a patient become pregnant is around 26%. We can conclude from here, the patient who became pregnant, it doesn't matter whether the patient had one child, two children, or even three. So still people had the urge and the will of becoming pregnant. When we do the t-test, we found that younger patients and the parity influenced the patient who wanted to become pregnant. So what are the treatment involved? Most of our patients, they underwent modified radical mastectomy, just like in the previous papers. Most of our treatment was, we were using anthracycline-based chemotherapy. Among the treatment, only few patients, around 15 to 20% of the patients, they underwent ovarian fraction suppression. Ovarian failure was experienced only in one patient in each group. At the end here, we can see the disease-free survival was even lower in the group of patients who became pregnant. No, actually, it was more comparable, 20.8 and 19.0 in the group which desired to become pregnant and those who became successful pregnant. So we went ahead to look who are these patients exactly who completed the pregnancy. So here we are comparing the characteristic. We can see that younger patients who less than 35 years old, these are the patients who had the will and the desire and they successfully became pregnant and delivered. Family history never influenced the decision. Again, here we can see the parity, also it was involved. Talking about the stage, most of our patients were stage 2, so only few patients were in stage 3. Talking about the receptor positivity or hormonal positive patients, around 60% of our patients were hormonal positive in each group. So we can see there was a balance in the amount in terms of receptor status. Type of surgery, more patients underwent modified radical mastectomy in the group of where they never underwent. In the group of patients who aborted. And here we have the survival. We can see the survival was the same in the group of patients who become successful and those who never became pregnant. And here, to be specifically, we are comparing the group of patients who completed a pregnancy and those who underwent abortion. The patients who completed pregnancy had better survival compared to the group of patients who aborted. So we can see from this one here, abortion does not improve the survival of our patient, so we should not be discouraging our patients. And these are my conclusions. Approximately 6% of the young patients had desire of becoming pregnant after breast cancer diagnosis. The mean age of diagnosis was 32 years. Most of the patients who desired to be pregnant were younger. Okay. So most of the patients who desired to be pregnant were younger, around less than 35 years old. Age and parity was the main driving force for the desire to have children. Overall, there was no survival difference between the patients who desired to become pregnant but were not successful than those who successfully became pregnant. However, among those who became pregnant, those who underwent abortion had worse survival. What is the future direction? Most of the available data on the safety and the timing of stopping endocrine therapy for one to become pregnant are based on the retrospective data. Pagani et al. Conducted a survey to see the willingness of young breast cancer survivors to take part in the clinical trial. They are now conducting a positive trial. They are going to see, so they have completed recruitment and we are going to see the results in the next future. So this will give us the guidance what to do with this patient. And this is my take-home message. I would like to thank you. First of all, I'd like to acknowledge again my supervisors, the Professor Abdulaziz Bilal, Professor Omar Shibli, Dr. Azad Darwesh. I'd like to thank all the staff of the Ebeaid and ACOD, the patients and their families, and thank you for your attention.
Thank you, Ebeaid. Few words. Ebeaid was the first speaker in this meeting who offered extra time without asking for it, right?
Yes, thank you.
So, and I have few words about our African colleagues and Ebeaid especially. Actually, you are part of us and you are the privileged resident who are trained here in the ACOD. ACOD is very proud that he had been trained more than 60 African students, mostly from Kenya and other countries, and I believe they feel very loyal to ACOD. And I wish they are feeling they really part of ACOD, because ACOD consider them the fruitful of our collaboration with Africa. Actually, we are very proud of Ebeaid. He is very active person. He is very active socially. He is very active in caring about his colleagues. He is very active in contacting the administration of the department for any problems with the African student. We are very proud of the African student, and we believe they will continue their attachment to ACOD after they finish their training and education in ACOD. Actually, I'm really appreciating everyone in this meeting who had delivered his maximum effort for the success of this. And Ebeaid was one of them. Thank you, Ebeaid.
Thank you for your kind words.
As a matter of fact, we have one session left, but the speaker has been apologized, and we are free now, and we will have our lunch early, and we will ask all of you to join us for a group photo, please.